It's my pleasure to introduce our next speaker. Our next speaker is Beth Kaufman. Beth is an associate professor at Stanford University Lucile Packard Children's Hospital. Beth is one of the leaders in transplantation medicine and also cardiomyopathy. She directs the cardiomyopathy program at Stanford. Beth is going to speak to us about some of the innovations in the field of not only cardiomyopathy, cardiac transplantation, but also cardiac ICU and cardiac surgery.
Thank you. That's a large agenda. What I did think I would talk about in the context of this Congress, where we had such a wonderful plenary session on the history of heart transplant and such a wonderful tribute to some of the true pioneers in our field, I thought I'd focus on a more recent era innovation. And that's happening during our career of younger and mid-level faculty, and that's in the application of long-term ventricular assist device support to children who require mechanical support as a bridge to heart transplant, as a bridge to candidacy. And this innovation is really come from the application of devices designed for adults, specifically continuous flow devices, that are now becoming miniaturized and small enough so that they can be fully implantable, allowing a child to be quite ambulatory with only depending on an external controller and battery pack. And these smaller size is now being applied to children with many different etiologies of heart failure requiring transplant. For an example, the child in the upper left corner, one of our smallest VAD patients. Our hardware is approved by the FDA only for BSA greater than 1.5. This child with a BSA of 0.7 was 7 years old and was able to be supported with an LVAD for 16 months while waiting transplant, almost all of which was outside of the hospital. The pioneers in the lower left corner there are two girls who both have single ventricle physiology. The child on the left is a hypoplast, palliated to a Glenn, systemic ventricular failure, implanted with an RVAD, a systemic VAD, and who's been supported now for 5 months awaiting transplant, most of the time out of the hospital. The child on the right, a variant of AV canal with a PA band, severe AV valve regurgitation, also implanted with an RVAD and a central shunt, has now been successfully bridged 7 months on device support and was transplanted just 2 weeks ago. At the right side of this slide, we see applications of VAD as bridge to candidacy for transplant. A child with metabolic disease was bridged to see if VAD support and robust cardiac output would stabilize her condition. And the child on the right was a gentleman with muscular dystrophy who had an acute decompensated heart failure, who was implanted with an LVAD, and then after some time of support decided he actually didn't want to pursue transplant, but has decided to remain on his VAD as destination therapy and is now 5 years in and a college graduate. So these are just some examples of how innovation in our field is being applied to our world of pediatric heart transplant. And this is happening at an incredible quick rate, similar to the early era of transplant. We can now see just from 2005 to 2014 in this chart from the UNOS database that the use of VADs as bridge to transplant has doubled in the past 10 years, with now 1/3 of all children being bridged with mechanical support, typically VAD. And it's working. What's most impressive about this Kaplan-Meier curve from the International Society for Heart and Lung Transplant Registry is that the children in green represent those bridged to transplant on VAD, which is almost indistinguishable from the children in the red line here who were not supported on VAD. And this is in extreme contrast to the blue line, which is the cohort who required ECMO as their mechanical support. And we can see the huge contrast in early transplant survival. Now, this does not just reflect survival bias, because we can see there's significant improvement in waitlist mortality as well. On the graph on the left represents the blue line as our early era of VADs from the early 2000s, with the green line representing our progress in the more recent era. And quite impressively, in the graph on the right, breaks down these time periods by cohort of those children who required VAD and those who did not. And we could see here impressively that children who were supported with VAD in the recent era, and this is just until 2012, actually had the lowest waitlist mortality. Now, this still represents a great need in our field because we see that children who were not supported with VAD in the recent era did not do as well. And that does represent the children with congenital heart disease and the smallest children. Those represented really do represent the frontier of our field. So in closing, I just want to really acknowledge, not only highlight VAD ventricular assist devices as an innovative technology to help improve the waitlist experience, to improve post-transplant survival, but also really to highlight our patients and families as pioneers in the field, as innovators, because it is their need which really motivates the innovation. It's the family of baby Faye. It's the family of all those children I presented early on who really, with their trust, allow us to be innovators and to make progress in the field. Thank you very much.